Hello, my name's Charlie, and I work in the National Maternity Team at NHS England. They don't let me out very often, so it's really nice to be here, actually. And this is one of the first times I've actually been able to speak not just to the sort of leads of an LMS, but actually to the people working within it as well. So it's a pleasure to be here. So does this work? It does. I've been asked to come and talk about some of the national policy work we've been doing on postnatal care. So just to summarise what we're going to cover today, we're going to recap the national case for change in postnatal care. We're going to look at national work to date and the key themes that are emerging from that. And I'd really like to use this session to sort of test some of those with you, talk to you about what's already going on here, because I'm sure there's already a huge amount going on, and perhaps what we've missed. And it was great actually to hear from our colleague in HE about, was it Groningen? Groningen? We'll get there. And I think it's funny, I'm a very keen cyclist, and I say, is it any wonder that we're sort of striving to be like Northern Europe, even in cycling? We're working at the moment in the national team on the long-term plan for the NHS, including for maternity. And I can't tell you the number of times someone from Simon's office has said, can't we just be more like the Netherlands with our home births? Can't we beat Sweden on safety and things like that? And you kind of say, that's a big aim, but we need to aim there. So what do I do? So I work in work stream 1 for the maternity transformation programme. That probably means nothing to most of you. There are 9 work streams in the maternity transformation programme nationally. Work stream 1 is the central work stream. It's the one that's trying to make change happen around the country. So, as I said, they don't usually let me out. When I'm locked in a dark room, what I'm normally working on is national policy around the formation of local maternity systems and then the assurance. So how do we do that? So we set the deliverables for local maternity systems nationally through the ASK. We look at what national levers we can use to sort of help drive improvement. So things like the CCGIAF, the planning guidance. We help support the regional delivery structure, so the regional boards. I lead on LMS funding, so that's the transformation funding that LMSs get every year to do their work. I don't know yet. Then finally, we bring together things like the bespoke support office. I don't know how many of you have seen that. So that's all the support that LMSs can expect to receive from all the national work streams. And then finally, we also do the policy on the assurance of LMS delivery through the regional boards. What we also do is we develop national policy in key areas where it benefits somebody doing it nationally rather than every LMS going and doing this work themselves. So what have we done so far? So we produced the LMS resource pack in March 17. We produced the continuity of carer guidance that was published in December 17. We're soon, I'm going to mention this in a moment, we're soon going to be publishing some guidance on postnatal care. And we're also just beginning to work on networked maternal medicine, so watch this space. So postnatal care, I think we all know what Better Births said about it, and I think we all know what Dame Sally Davies said as well, that postnatal services are the Cinderella service, they're under-resourced and they're overlooked, and that commissioners and providers must attach sufficient importance to securing high-quality neonatal and postnatal care. Now that was November 16. I know that a lot of work's been going on since, and perhaps we can talk about some of that. But we also know that postnatal care in particular is the bugbear of a lot of the sort of significant sort of women's representatives groups nationally. So the NCT and Mumsnet have both done big surveys, and they're now running campaigns about the postnatal ward experience and things like that. So what did Better Births say about what makes good postnatal care? We'll just do a quick run through. No surprises here. Led by the woman's midwife, who should help her to develop her postnatal personalised care plan. There should be support for transition to motherhood, including breastfeeding. We should be asking at every contact about maternal well-being and looking for early signs of mental health issues. We can talk more about that later. Comprehensive handover to the health visitor and the baby. a 6-week GP check with sufficient time and clarity about what it will cover, and I appreciate nobody in the room can do anything about that. Following the trauma, a multi-professional debrief and handover between labour and postnatal care, and better support for breastfeeding that empowers women rather than pressurising them. What it didn't go into, really, was exactly what LMSs needed to do or how they might go about bringing about these improvements. So we decided that perhaps this is an area where people would benefit from some national guidance. So we brought together an expert reference group under the leadership of Dr. Jackie Cornish, who I don't know if you know, she's our National Clinical Director for Children and Young People. And we brought together, it felt like a cast of about 1,000 people actually, for all of the people who have oversight over postnatal care. And that was a group that was really difficult to sort of manage the numbers on, actually. And postnatal care is an extremely tricky area because I like to think of it as a sort of a corridor to 1,000 rooms. And that's the challenge with sort of developing national policy on this, and that what every woman needs from postnatal care is, of course, completely different. So we met 4 times to look at what recommendations we might make for improvement. And the postnatal ERG has made about 27 recommendations that I'm absolutely not going to burden you with because we don't think that's fair on anyone. What we're going to do is bring that together into some guidance. So in making these recommendations, and this is a slide recycled from the first meeting of the ERG, we sort of had to explain what our limitations in this work were. So firstly, Health and Social Care Act, of course we can't tell people what to do. Secondly, we know that NHS services are really overstretched. And we know that we can't really be seen to be imposing anything that's going to add to the burden, add to cost, and all of the work that we need to do. And this is the real role of the LMS, is to do that transformative work, that work now that's going to make a difference that we can then put into business as usual for later. And finally, as demonstrated by this picture here, we know there's a huge amount of guidance around all the different elements of postnatal care. And what more than anything, we don't want to hit anybody with another massive guidance document that people then have to unpick and sort of contextualise with everything else that's going on. We want to keep the message simple. So what's coming? This winter, we're going to produce some guidance on postnatal improvement and best practice based on the ERG's findings. And we're going to produce a bit of an indicator, a bit like the CCG IAF perhaps is a way of thinking about it. Has anybody looked at the maternity panels ratings for the IAF? Is that something that people have looked at? What we'd like to do, we'd like to take the CQC survey, and we're going to select questions through the CQC survey and create a sort of an indicator, and so to compare LMS and how they're doing, and to give LMS something to really work upon. I think one of the wonderful things about the CQC survey, and something to take heart from, is that the results from women are improving every year. Postnatal care is no exception to that. One other thing that we're thinking about is perhaps thinking of clarifying the ask to LMSs about postnatal improvement plans and what those should include. So we're considering that. So one of the first things that we found was that there's a huge amount going on in better births already that's going to lead to really big improvements to postnatal care. So even if this guidance didn't come out, I think we could expect to see a real step change in the experience that sort of women have. The first one, and the most important really, is around continuity of carer. We know that services are finding this really challenging. We know that midwives find the idea of working in a new model of care perhaps unclear and intimidating for that reason. But we know that having continuity of the midwife who's looking after you through your care will make a massive difference to the quality of your postnatal care. We know what the Cochrane evidence says about outcomes and women's experience. Women are much more likely to feel happy with the advice that they receive, about pain management, and they're more likely to feel in control, which is, really important. I was looking only last night at some early evaluation sort of results from the Royal Free in London, looking at the women that have been through a continuity of care model, and it was really amazing to see the significant reduction in low-risk women for emergency caesareans, the massive reduction in instrumental births, and so the flip side of that, the increase in spontaneous vaginal births that we saw. And then what was really striking was to see for vulnerable women the reduced admissions to the special care baby unit on site. And what was even more striking was the reduction in the length of stay. It was massive, it was a cliff edge. Early days, it was quite a small sample size, but across that we saw that not only did it provide an improved experience or after the birth, but we saw that it was saving money as well. Okay, so personalised care plans, just as important in postnatal care planning as anywhere else. We know that North West London, early adopter, have done some fantastic work about personalised postnatal care plans. You can reach that on the Local Transformation Hub. The templates are all online. If you go on the Local Transformation Hub, they're all there for you to download and for you to take a look at. There's work going on nationally around neonatal care and Attain. So NHS Improvement, we know, are working quite hard on encouraging services to fund transitional care services so that more women with babies that need additional care can stay with their babies for less serious conditions. Electronic care records. What is postnatal care if not a series of sort of transfers of care? Firstly, from the hospital into the community, then from the community over to health visiting and to GPs. And we know that NHS Digital, where's Benedict? Oh, morning. Are working to look at, interoperable care records and also shared care records so that, women, even if they don't have continuity of care, don't feel like they're telling the same story every place that they go. Community hubs. So I know that even in this area, a huge number of community hubs are springing up. They're going to make a big difference to the postnatal experience. You can have a one-stop shop. People know where to go. They've been there before, and I think that's going to lead to improvements there. I've talked a little bit about the work of the early adopters. And finally, Maternity Voices partnerships. Do we have MVP representatives? Brilliant. Hello. We know that we've got 100 now running across the country. And we view these as an absolutely essential sort of conduit for getting feedback from women, but also for co-producing your services and for thinking about all of those little details that perhaps we don't think about, like the way that the rooms in the postnatal ward are set out. Simple things, really simple things that make a big difference. Externally, we know that NICE are refreshing clinical guidelines, CG37, on routine postnatal care. But that's not coming for a while. We've also questioned what routine postnatal care is, given the number of women that need additional care, and the number of sort of different types of support that a woman might need in that period. So, what did we find? So what I'd like to do with these. There have been 27 recommendations. Some of these are sort of national level that we need to take away and work on, things like the GP check. But there are other things that we think that LMSs can probably provide leadership on and sort of help working on together. And I'd really like to sort of go through sort of some of the key findings in the round and sort of just ask you what's being done here and where do we think LMSs in particular can sort of add some value here, and where do we think we can provide improvements. So we kind of looked at things across the pathway, and so the first thing that we felt that we wanted to look at was the communication that women receive after birth. I don't think we're going to say anything here that's going to blow anyone's socks off. I think everyone knows how this works. But I think this is about looking at where we can make small improvements and where we can do everything that we already do a bit better. So the first priority, of course, is keeping the mother and the baby safe. We need to provide clear advice on the risk of complications for both the mum and the baby. We need to make it clear to them what's normal, what's not normal. But there are also a huge number of issues that mums need to know about after the birth that are of less immediate concern. And actually, the information that mums need varies massively depending on their individual circumstances. And we know that mums, you know, if you've had a long labour, you're not always receptive to large amounts of information in the period immediately after the birth. It's so what does that mean? What does that mean for the kind of information that we're giving to mums and when? So we need to be thinking about the timing for this. We need to be thinking about the quality of the information that they're receiving. And we need to make sure that every mum has clear information and that they know who to contact if they're having any problems. So my question to you is, what do we already do? So I mean, the ERG have heard, I know, we've heard too many stories, and these are anecdotes and they're nationally of, you know, we've all heard horror stories of women with an emergency C-section who's back at home, major abdominal surgery, hasn't got a printed leaflet even to tell her, you know, how to look after her wound or just to remind her of what's right and what's wrong. So what do we do already nationally, or what do we do here in Lancashire and South Cumbria to make sure that women always receive the right information? And perhaps is there a little bit more that we could do as an LMS to help women receive clear and consistent information? Can I open that up? Does anyone have any thoughts on that? Hello?
What we really need to be doing is including our MVP in this to tell us what we need to do. And also, today in our audience, we've got someone from Dadsnet, and that's Graham sat in the front row over there. We're already doing some of that in sharing our information with both of those locally to say, does this make sense? Is it readable to you? Is it what you want to know? What questions would you rather have asked? And I think as provider trust, understanding from our MVP and Dadsnet and others that might be that are using our service, what we actually need, and then us tailoring that to their need. And using that authority, because we've all got systems within our trust where information leaflets, for example, need to go through. But actually, these groups are our information group, you know, so we don't need to send them through another group within our trust. We need to make it in our LMS that is our information group, and then whatever is said in any local area that we share across the whole LMS.
I think that's right. I think we're going to be talking about, MVPs and the roles of dads groups as well, I think quite a lot this morning. And we can't take a message given as a message received, I think, and that's why sort of seeking feedback on the information that we're giving out, I think, is so important.
It's just a comment, really, a very obvious one.
Please.
Most young women will turn to the internet for information and advice rather than leaflets. That's not to say that leaflets are not used. So I think going back to what we were saying about digital, I think that has to be the way. And so that almost makes me think about how we would coordinate that, because information for women in Lancashire and Cumbria will probably be very similar, if not the same, for women in Cheshire and Mersey or in London or wherever. So there's probably something that needs to be done as a collective that can move faster, given that digital information and technology does cost. So that's just
I think that's a really fair point. But what's interesting is that even when you look on the internet, the amount of conflicting information that you can find can be quite bewildering, actually. What people are really looking for is for an authority that they can trust. And you know, first and foremost, we want that to be people's midwives. But actually, I do take your point on board. There is a piece of work to do nationally, I think, to look at the information available, things like NHS choices, to make sure it's all consistent. And we are thinking of actually bringing together a bit of a reference group to look at perhaps a bit of a standard checklist of all the things that you need to cover off on discharge into the community.
Just on the digital, before I bring Graham in, the postnatal group, Fiona, have started to think about, haven't they, doing like YouTube clips of key information and things like that to put online for postnatal? Yeah, I can pick it up afterwards, but yeah, they started to look at that as a group in terms of that snapshot. And I think NHS UK, that was NHS Choices, is fantastic as a resource, but it is, if I dare say it, it's not very that user-friendly. It's got hundreds and hundreds of pages of text So that sort of, short, snappy, and we're thinking about, message in a minute type approach that we took at East Lancs at one point. You can get an awful lot of information into a minute's worth of a YouTube clip that is probably going to go down better than 6 pages of text, which for some people, obviously there's horses for courses, isn't it? But we need to think snappy sort of information.
Thank you. One of the main things we've been talking about as well with Kathy and a lot of the maternity services is informing the partners, so that the partners can, because the mums have got so much going on through their heads at the time, obviously concentrating on the birth. If the partners are fully informed and they know everything, they can then assist the mum in the postnatal care. They can help with the things that the mum won't remember, and they can do just those little bits that help. And we find that kind of cancels away a lot of the stress and takes a lot off the mum and the midwives as well.
I think that's right, and we're going to talk about birth partners in a minute, but actually, birth partners are there not just for the birth; they're there throughout the process, actually, and perhaps that's something we could consider. One point about national sort of information. One thing that we think is really important is that when mums go away, they go away with someone's name or a phone number at least, who you need to call if you've got a problem. And we can't do that with national resources. So if we can create a template or something like that that can be adapted locally where that information can be put in, we think that would be helpful. But anyway. Sorry.
Yeah, I was just going to say, my name's Deborah Wilson, I'm Head of Nursing at Lancashire Care. I think we need to make sure, and we are doing this, I think, within the postnatal work stream, is that we consider the wider workforce, because it's not just around midwives who touch people antenatally or have those touch points. So you've got your health visitors, you've got your early help teams, depending on where you come from within Lancashire and in Blackburn and in Blackpool. So it's about making sure that we're all singing from the same hymn sheet, we're all using the same information, that people are getting consistent messages. And that goes right through from antenatal, right through to into the postnatal period. And it also covers things like perinatal mental health, etc., so that people are really well informed about what they want. And that's not just mums, it is dads as well.
Yeah.
So we need to make sure that it's all encompassing. And it's for our looked after children, it's around their foster carers. There's lots of people that we need to be pulling in on this.
Thank you. I think that's absolutely right. And we're going to turn to health visiting and perinatal mental health, so thank you. Okay, I'm going to move on now, if I can press the button properly. There we go. Right, so just going to move on to the postnatal ward experience. So I talked earlier about surveys that NCT and Mumsnet have conducted, and what they show us is that relatively small and non-clinical issues can have a big impact on women's experience of care. Things like swift access to advice, access to food and water, light and ambient noise levels, and support from their birth partner can make a massive difference, can make the difference between enjoying your experience or getting through your experience in the postnatal ward, or discharging yourself because you just can't bear to be there any longer. And in some surveys, that's as many as 15% of women. Now, as part of that, we talk about support from birth partners, and it's great, Graham, to have you here. We know that they have a significant role in supporting mothers. So whenever we've gone out to visit services and talked to them, I went to the Whittington Hospital in North Central London, and they talked about the role of birth partners in providing a lot of this support. But it's amazing what a controversial issue birth partners on postnatal wards is. There were some absolute arguments in the ERG about this. On the one hand, we had people who saw them as the answer really to overstretched postnatal wards where you've got 2 patients in every bed and midwives are struggling to get around. On the other hand, we heard anecdotal stories of fights and inappropriate behaviour that people felt that new mums needed to be protected from. I saw a survey actually conducted in another North London hospital where they asked mums whether they supported the idea of birth partners staying in postnatal wards overnight. And the results surprised us actually. 88% were in support. And what the survey showed us was that support for dads being present had no variation across cultural or religious backgrounds, as you might have assumed. So what we would really like to see is every LMS having a birth partner policy that is as empowering to birth partners as possible. And once again, we know that MVPs are a really important forum to get feedback on the postnatal ward experience. And the question that I would ask you all is, have you done the 15 Steps Challenge in your postnatal ward? Have you walked the patch with some local mums? Because I think that's a great opportunity to get some feedback. Brilliant.
Just say thank you to whoever's posted the first Slido comment.
Oh.
Hey, whoever it is has put in, based on the last discussion point that you had, Charlie, that in Pennine Lancs information is shared via service user on the Facebook, very, very active Facebook page for birth in East Lancs. So that's really useful. So
That's fantastic.
Please use Slido if you don't want to use the microphone.
We like the microphone though. Does anyone have any questions about this? So what services, what do you already do to ensure that women will be provided with personalised care and choice in the postnatal period? And what work are you doing to make sure that the postnatal ward experience is monitored and improved? Does anyone have any thoughts on that?
Hello, I'm Tracy Thompson. I'm a matron at one of the local trusts here, East Lancashire, and I've been the postnatal matron for the best part of 4 years. And we're well aware of the postnatal care and the restricted postnatal care and timing to be able to debrief mums, and that does have a knock-on effect in future years and future subsequent pregnancies. Having just done the 15 steps with our local MVP, I would just like to ask the question of where the professional midwifery advocate fits in to the holistic model and workforce planning, because having done the bridging module of recent, the restorative, contained, reciprocal approach to supporting midwives in order to then support mothers and fathers in the community, I feel is something of great benefit for the future. And has there been any considerations with regard to funding of the PMA roles?
We're talking about A-Equip, the A-Equip model here, are we? I'm really sorry, you've got me there. I would have to refer you to one of our colleagues in the midwifery leadership team about that. So actually what I can do is I can take that question away to either Jan or to Claire, Jackie Dunkley-Bent's deputies, and we can talk about that. Yeah, sorry.
Yeah, we talked about true transformation and the alien coming in and saying things. So when we talk about postnatal transformation, I personally am not seeing anything planned that will make the alien think anything's different. And you talked earlier about looking at Northern European countries. Postnatal care, the way it's delivered in the UK, is a very, very British thing. You will not find postnatal wards in European countries. It's just, you may have women staying a day or so after cesarean section, a day, but the way we deliver care is centred around what the service needs. I.e., we keep women in because the babies aren't feeding well. Really? They're going to feed better if they remain on an NHS ward than they are if they go home and get the support at home. So personally, I feel it needs radical transformation how we deliver postnatal care if we're going to make a difference. Because what we're trying to do here is fiddle at the edges by improving things within the system that is centred around what the services can do.
Certainly, sorry. On one of those points around keeping women in because of feeding issues, I know in one of their areas that have moved ahead quite a bit with their community hubs, that they offer that so women can go home very quickly, but actually they can access as many times to their local community hub to get that support around feeding, going in 3 times a day if they wish, or whatever, to get that support rather than, like you say, staying on a ward. Right, I've got a couple of people.
I think that's an absolutely fair point. But I think some of the biggest changes are already happening. So when we talk about things like continuity of care, we're moving away from staffing buildings to staffing women. And if that allows more care to be provided in the community, supported by community hubs, then I think we are going to start seeing those changes. This one piece of guidance is not going to be the silver bullet that changes this, but I think there are actually a lot of things across the programme that are going to make a real difference. And if we're doing them all together in the right way, I think we can take people out of postnatal wards a bit sooner, if it's appropriate. Hello.
My name's Lizzie. Apparently the microphone's allergic to the baby. I'm from Morecambe Bay area. Hello. And I'm a service user rep and involved in the Maternity Voices Partnership. I wanted to back up what you say about personalised care. That's really important. One of the concerns that people have around, say, community hubs and things like that is for women who have had more difficult births and C-sections, how they access that care. So that's a conversation that we're having locally, because after a C-section you can't just like, well, I'll just pop down to the local community hub.
No.
That's not going to happen. So there's a conversation around the personalisation there. And also for those areas that don't have partners staying over in the postnatal ward, it's something that is happening in Morecambe Bay. And I can speak personally at how much it can change your postnatal experience. And this is what I'm hearing from women and families who I talk to in baby groups as well. So if anyone is concerned about that, please come and talk to us or talk to someone else from Morecambe Bay. The difference between my son 4.5 years ago and my daughter 6 months ago, my postnatal care was transformed partly because my husband could be there. And it really does make a difference. So anyone who has concerns about that, please talk to Morecambe Bay, please talk to me, because I would urge you for that to be an option for women. Not a necessity, not a replacement for care, but an option.
Do you know, if I could just get some service users to stand up and say all the right things in the right order, I just don't think I would be necessary at all. It's much better said. Thank you very much. It's much better said. Okay, shall we move on? Yeah, we'll move on. Oh, so infant feeding. It's another quite touchy subject, I find. Now, what do we know? We know that the benefits of breastfeeding are clear, but that mothers need practical support to help them breastfeed rather than pressure. We know that UK breastfeeding rates at 6 to 8 weeks compare poorly with other countries in Europe. And if we look even within our own country, we've got significant regional variation. PHE data suggests that in London, 84% of women were breastfed at 6 to 8 weeks. The average in the North East was 32%. And we know that rates of continuation also vary in accordance with socio-economic status and ethnicity. Having said this, we must acknowledge that some women can't breastfeed or they make a choice to do so. So we know that there are some fantastic accreditation schemes out there. Brilliant to hear, was it that in Lancashire we've got one of the first gold-rated units? The only in the world. I'm going to say something that I'd like to be edited out of the video. I can't tell you how difficult it is for us to produce guidance or to ask you to do things that cost more money. And BFI accreditation is one of these things. We know it's one of the most structured schemes to help people improve their breastfeeding advice and their breastfeeding offer. We are getting a lot of pushback nationally that, don't you know that costs services money? And how can you tell them to do that in times like these? But what I will say is it's brilliant to hear that services are going for gold on that in Lancashire. So aside from that, is there anything that we think that the LMS can do to support women to breastfeed across the patch to make sure that women are getting consistent information and advice? Is there anything perhaps that we can do at a system level to look at the trends locally? Can we speak to our MVPs to try and understand perhaps what differences we've got within communities inside your areas in terms of their approaches to breastfeeding? Is there anything that being done like that?
I suppose from my from the point of view, it's no different to... Hold on, Kate. Quite loud. It's a public health intervention. It's no different than smoking cessation. It's no different than many other interventions that we do. It's an educated workforce that empower good decision making and advice and support. And I think, I think that sometimes it's wheeled out as a standalone, infant feeding is put on the side, and I think it's fundamental through that whole journey, and I think it's about continuity of message. It's, I think earlier we talked around trust in messages, didn't we? Trust in professionals, and I think that even the right message sometimes gets lost. So, the right professional saying the right information gets diluted and lost because of the, as you say, the myriad of so many different things. So I think there's not one thing that we can do. It's weaving it into every single thing that we are doing, every policy, every antenatal, postnatal, MVP, partners. It's part of everything.
I think to add to that, you can get the right advice all the way through your antenatal care. And then when it comes to actually breastfeeding, people think it's going to be easy, and what I hear is that it's not, it's painful. And when you need support with that, you need it then. And even if you get the advice all the way through your antenatal care, if you haven't got someone that you could speak to help you through those early days, that's when you see a lot of people dropping out, right? And what I wondered is there something, we talked about the role of maternity support workers. Is there perhaps a role for maternity support workers in making sure that women have that kind of round-the-clock support when they need it?
Absolutely. And am I on? Yeah. So, and I'm going to talk later about how in London, if we use them as an example, they're coming up with a breastfeeding-friendly borough, so it's everybody's responsibility. We have that culture where, and I think parents and families and communities need support to feed their babies and care for the babies. And I think that, their expectations and everything, however their baby's being fed, they need that support at every level. So, that's why I think infant feeding, feeding babies, caring for babies is probably a really useful language, isn't it?
Yeah.
Just really quickly, I'm Kate Ismail from Central Lancs MVP. Just to say that what women say to us when they have wanted to breastfeed and they've gone on to successfully breastfeed is that they've had support from an outside service. So FAB or La Leche League, FAB is the main one in Central Lancs. So I would just say, look at what they're doing. Look at what they're doing, how they do it, why it works. I think I don't know exact figures, but their rates are 80, 90% success rate, women that they see a few days after coming off a postnatal ward or having their baby. And for people like me, I wouldn't, this is my fourth baby, I've breastfed all four. I would not have done that if I had not had support within the first 3 days of returning home from FAB.
So what is FAB? Is it a local
Families and
authority
babies.
commission?
Yeah, it's a
the third sector. Brilliant. Okay, well, that's something else that I think we need to tap into.
Yeah, almost every parent that we speak, a mother we speak to that has successfully breastfed has had some additional support from a third-party organisation like that.
That's right. So I think third sector is probably a much nicer way of saying it than VCSE, which I think is an absolutely hateful acronym. I think it stands for Voluntary Community and Social Enterprise Organisations.
I think one of the issues that somebody's put on Slido around that is that, they're coming in thick and fast now, is that because many of the breastfeeding services are third sector, that they seem to constantly change when commissions are changed, because they're sometimes temporary funded, aren't they? So you think you've got to grips with what your local group is, and then it's commissioned from somebody else. So we just need to think about the long-term consistency about those services, don't we?
I think that's something, that's an issue. It would be a challenge for us at NHS England to deal with that. I think that's a local commissioning issue, and if there are local commissioners can do some work to provide consistency there, I think that's where we'll see a real difference. But we need to tap in, but I think we do need to tap into the VCSE offer, and we need to make sure that women are aware of that. And I wonder whether MVPs have a helpful role actually in helping sort of create a roadmap for those in partnership with their LMS. I wonder whether that's something where an MVP could add value.
Somebody's asked around examples of digital support for women in the middle of the night. Well, I know you can ask Alexa, can't you? Alexa will provide you with middle of the night breastfeeding support. They will.
Is that right?
She is programmed to support you in the middle of the night. If you have an Alexa, she will talk to you about your breastfeeding problems. I'm just going to go to Kelly and then I'll come back.
Hi, Hi, so coming at it from a different perspective, so I'm from the neonatal network. So we do have national data on our breastfeeding on discharge from the neonatal unit. So the National Neonatal Audit Programme produced data for that. We don't do very well in the Northwest, to be fair, but we have lots going on from a neonatal perspective around trying to improve breastfeeding rates. And we know that if a mum expresses within an hour to 2 hours of delivery, she will have continued breast milk supply. So it's not just trying to convince a mum to continue to breastfeed. From our point of view, we have to keep the milk going. And we know that we as a neonatal service can't always start that process. Working together with our maternity colleagues, thinking about a role of a maternity support worker. Somebody, as we know, a midwife is busy post-delivery, but somebody needs to be there in that first hour to support a mum in starting that process of expressing milk that will help her to continue to produce milk, potentially for when her baby is discharged after a journey on a neonatal unit.
I'm really glad that you said that, and I think there are so many things there. There's firstly all the work that we're doing trying not to separate mums from babies in the first place, but secondly, the neonatal units are there, the breastfeeding support needs are exactly the same, so can we be more flexible with our workforce on that? And secondly, have you looked at accreditation? Have you looked at BFI? Have you looked at all this?
There is a neonatal section, so BFI accreditation across maternity services.
Yep.
But there is also a neonatal BFI accreditation, more money, clearly, but across the network, across the Northwest Neonatal Network, it is something, certainly in the Southwest, that they've looked at a network price for supporting that on neonatal
Brilliant.
units, and something that we, as the Northwest, are going to jump on the bandwagon of that, because we are working with UNICEF to create a combined price to try to reduce what it costs.
That's really helpful.
Across the network.
If there's anything that we can do to help with that.
That's what the approach we're taking with the LMS to support units to become. I think the UNICEF and the BFI team are really up for working differently with systems now in terms of looking at efficient ways of getting that accreditation rather than having to do everything 4 times over in one system area, which is really useful.
In addition to what everyone has already said, I think there's a couple of things we could do. Working with our obstetricians so that practices such as immediate skin-to-skin are possible for anyone, whatever sort of birth they have. So I had a planned C-section with this little one. We had immediate skin-to-skin. It was lovely. And backing up what Katie says about the inclusive language, we need to stop just talking about breastfeeding. We need to be talking about caring for our babies, feeding our babies. And something that I think really would help is antenatally talking about risk factors for delayed onset of milk, risk factors for breastfeeding not working very well. It seems like it's a bit of a taboo subject. In fact, the Baby Friendly Initiative, actively says in its guidance, we shouldn't talk about breastfeeding as difficult. I think we're actually setting up people to fail. And for people to think, and for people to think, and so I do a lot of stuff online, and a lot of the women who talk to me are women who have had struggles with feeding and have had sometimes quite serious mental health impacts and physical health impacts on their babies from their quote-unquote failure to breastfeed and some of the language and some of the care they've received. And, on another head, I'm a county councillor, so I'll pick up what we're talking about, not having consistent commissioning and, having a county council that's funded properly so we can do our public health work properly would be great. So it's a really difficult subject because it is very emotive, but I think we need to maybe try and be a bit more honest with women beforehand. So when, they have an emergency C-section, which they're not expecting to have and lose lots of blood. It took me 2 years after I had my son to know that losing a lot of blood can affect your milk supply, that sort of thing can affect your milk supply and how to cope with that. It's only recently Baby Friendly started talking about combination feeding, looking at the evidence. There's actually some evidence now that very early, very limited supplementation, along with all the things that we know is good for promoting breastfeeding, can actually prolong breastfeeding. Now, that needs to be looked at more. I'm not saying that's a strong body of evidence now. But I think there is something that we need to change in the conversation and something that maybe the Baby Friendly needs to work on a little bit more.
We talked about trust in the information that you receive. I think people appreciate honesty more than anything else. And perhaps there is something about not saying that breastfeeding's really hard, you know, putting people off beforehand, but perhaps there is a little bit of dose of honesty there as well about saying, you know, but not everyone takes to it immediately, and there are problems with that. So that's something that we can feed back, actually. I've heard that quite a lot, and that's, you know, I speak to Francesca Entwistle at the BFI scheme, so that perhaps that's something that we can mention to her.
Okay, I'm just going to put Arif, then Fiona, and then I think we're going to have to move on.
Hi, good morning. Arif Rajpura, Director of Public Health, Blackpool. We have very low breastfeeding rates in our town, and it's been a real struggle trying to get those figures up. We've tried various things. We're trying a new model of sort of that peer support straight after birth. I suppose it is a wider issue, isn't it? It's trying to ensure that the businesses are receptive to having mothers breastfeeding in their cafes and other businesses. So it's a bit of a cultural change that we need across Blackpool. There is this cultural acceptance of bottle feeding within our town that we need to change. So there's a whole cultural change that we need to do in Blackpool. But I suppose the challenge I'm going to pose back to the centre is my public health grant has been cut year on year since 2014. I'm going to lose another £500,000 next year. The Secretary of State has talked about prevention and the importance of investing in prevention just on Monday. And unfortunately, the public health grant, which is a health grant from the Department of Health, has been cut every year. So what investment we can provide gets eroded every year in terms of, and this is a really important intervention. Infant feeding is really, really important. If we're going to improve health and inequalities, reduce inequalities, we have to start with children. And my message back to the centre is, if you want to get serious about prevention, you need to invest in it. And please do not cut my grant. I don't want to stop stuff in Blackpool. Thanks.
I think that's absolutely fair enough. But this public health grant, is that from DH or is that local authority?
No, it's a Department of Health grant that comes to the local authority. So back in 2013, my function moved from the NHS into local government. Yeah. So I moved from Blackpool PCT, as it was, into Blackpool Council. Yeah. And at that point, I took my team with me. We took our grant with us, and as soon as we entered local government, they decided to cut us. So since 2014, I've had 2.2% of my grant cut. And then there's all the other local authority cuts that have happened. All the children's services and the early years support that's provided through local authorities has also been severely cut. So I think it's very narrow. It's very narrow just to look at the NHS. There's all the other stuff, the support that families get from the local authority, particularly the public health grant. So the public health grant actually commissions health visiting and school nursing. And that grant is being cut. So it's just nonsense. It really is nonsense. And I'd like you to feed that back to the centre. It upsets me that I have to cut stuff because the centre is cutting my grant.
So I would say the maternity team at NHS England, we share your frustration. I've worked separately in maternal smoking as well, and I know that Blackpool is similarly challenged in that area. And one of the biggest problems that we see is that disconnect between NHS and local authority funded services and the disparity in funding that's being received there. All I'll say is that, we do have an opportunity through the long-term plan for the NHS to look at perhaps how we might be able to bridge some of those gaps, and we are looking at those. And but unfortunately, it's certainly out the gift of my team. But this is something that we are feeding back. Our whole organisation is feeding back, I think, up to DH quite often.
Okay, one last.
Yeah, I'm Fiona Hamer. I'm one of the obstetricians from East Lancs, and I'd follow on from what the lady behind said, that I think some postnatal problems are as a result of people's unrealistic expectations of what birth and can hold. So, you know, we're obviously trying to not to frighten people, you know, not to frighten people about breastfeeding, but not to frighten people about what their possible experiences in labour and delivery will have. But I think sometimes people come into labour having sort of no experience of what it will be like, and even what we think of as a pretty straightforward birth, some people find, you know, horrifying, traumatising. And I think, you know, there's a balance between trying to support people and telling everybody it's a natural process, you know, it's normal, without, you know, there needs to be a bit of a dose of reality, I think, about what's involved.
I think one of the key themes of Better Births is about choice and informed choice. And what is informed choice? Informed choice is having the right information and having open and honest information about what's about to happen. What are the risks of different models of delivery? With breastfeeding, why should it be any different? I think people do need honest information about the experience. And we're going to talk about birth trauma and things like that in a moment, actually. So perhaps we'll move on. So we then spoke about, you know, I just want to thank my colleague over there for mentioning perinatal mental health. We then spoke about emotional well-being and mental health. And I think one of the most interesting things that we concluded as a group was that every woman is at a risk of experiencing a mental health issue in the perinatal period. We had a couple of consultant psychiatrists on the group, and they were talking about the what they called the Hunter-Welly effect, where, you know, a woman comes in, she's driving a Land Rover, she's got a fancy pair of wellies on, people go, oh, you're going to be fine, you're going to be all right. But we know that women who are higher educated and have more socio-economic attainment are just, if not more likely, actually, to experience problems immediately in the postnatal period. So we need to be aware of that. And I don't think anyone's going to be surprised here when we say that every professional in contact with women can play a role in supporting emotional well-being and identifying issues. So perinatal mental health has to be everyone's business. And I know that our colleagues in HEE have been doing some helpful work in this area, for example, with the perinatal mental health competency framework, talking about the sort of training that's required to be able to provide this advice and screening. And I know that there is some work that perhaps LMSs are doing to look at their workforce and say, actually, where are the gaps here in the training that we're offering to staff in contact with women? And we know also that where women have had experiences that they weren't expecting, where they didn't feel they were in control, we know that being able to discuss the birth experience afterwards is really important. So being able to have, I've heard that debrief isn't a word that people really like. Some of the language is birth afterthoughts sessions. I don't know if you and the MVPs have ever heard of this. I'm just trying to get with the lingo, but it's really I'm sure this has already been done. But the opportunity for mums to be able to come back to speak to their consultant, to speak to the midwife leading their care, and be able to talk about their experience, even 6 or 9 months afterwards, we know that that's really important. And then finally, we've already spoken about this, but you know, we hear the saying that it takes a village to raise a child. But all too often, particularly in urban areas, mums can find themselves isolated without just that support that they need. We know the massive role that third sector organisations play in just giving people a sort of community. You know, we have organisations like the NCT, but the NCT costs money. And we know that community centres around the country are being closed down. And it's really important to be able to signpost people to the sort of postnatal services that anybody can access, even if it's just a support group. I'm seeing.
Yeah, you're saying NCT costs money. Postnatally, I mean, the groups that I've been involved in are free of charge, and if you want to buy a nice coffee from the nice cafe that it's organised in, then yeah.
The antenatal classes cost money today. And is it clearly signposted to people that perhaps looked at the antenatal classes, decided that's not for me, that they can still join in postnatally, and that's...
I would say so, but again, I'm not looking with fresh eyes. I'm not, you know, I knew about it, so it's hard for me to judge, but we can certainly ask the question.
That's good, but my intention was not to knock the NCT. I think we think the NCT do an absolutely fantastic job. Yeah.
Postnatally, I just wanted to make clear that is not the case. You don't pay to go to an NCT group.
Good. I think that's good. I'm relieved to hear that, but I think there's a lot of other groups out there as well, and we need to signpost them. And I wonder whether there is a bit of work that MVPs could do with LMSs actually to map out the local support offer to mums. And we know that recent mums are the best sort of pioneers of going out and finding those things. So if there's a way that we can signpost that to women, we think that would make a real difference. Okay, so shall we open that up? What do we already do to make sure that all women receive effective mental health screening and that we have access to emotional mental health support? Graham.
I think one of the main things is something you just touched on there was signposting. What we found a couple of years ago when we had our child is we didn't know anything about anything and we didn't know where to find things. There was no signposting, there was no advice. We had to basically go out there and search for it ourselves. Whereas at least if people can see either the mental health providers or midwives or anything like that can at least put people in the right direction and say, right, you can get this kind of support here, this here, there's these kind of classes here, this here. At least then people know and are well in advance that they know what they can do and where they can get it from.
That's really helpful, thank you. Just to add on that, we know that some LMSs have done fantastic work bringing together standardised information postnatally. So North West London Early Adopter done some fantastic work bringing standardising the information that's given to women across all of their trusts in their patch, and it's received really positive feedback, and I think we have examples of that on the Local Transformation Hub. So again, if you want to see that information for inspiration, please go on the Local Transformation Hub. Hello.
Hi, just a few things. One of the things that we hear, I've just on the previous screen, you mentioned that women have experienced a feeling of loss of control. Quite a lot of the women who have mental health problems after having a baby have had a loss of control enforced on them during their labour and their birth experience. So the problem actually exists within the system where they gave birth to the child, not with their ability to cope with having a baby or giving birth. And I just wanted to clarify that because that's often most of the women that we speak to have had issues afterwards, that there has been some element of something went wrong with their care and it wasn't their fault. So just wanted to make that point. Also, when mental health is concerned, often it's parents. So to follow on from what Graham was saying, it's not just mums, it's mums and dads, and about that unit as a family that's been, and the village to raise a child sort of thing. The children's centres are being eroded because obviously a lot of that information you just mentioned would have been from children's centres originally. And perhaps one of the reasons why people aren't being signposted or getting access is because services are being cut and there isn't access to that. And my third point was black and ethnic minorities. I think there's a huge issue with access to healthcare, to mental health care, to services after having a baby and before having a baby. And we know that black women are more likely to die in childbirth, ethnic minorities are less likely to breastfeed. It's quite relevant to the area that we live in. There's a lot of, and I don't know what to do about it. I just think it's it's a real piece of work that needs to be done, that needs to be thought about, that needs to be, if you want mental health to improve and if you want breastfeeding rates to improve and you want access to service to improve, then it needs to be all-inclusive, and it's not currently.
I think that's fair. I think the Embrace report that came out this week has shown some really stark inequalities. No, it is, and we need to do something about it, and we are beginning to do some work to look at that nationally. The picture, when we talk about minority backgrounds and breastfeeding rates, it's a very varied picture. It's not as clear cut as that. And we know that between different communities, actually some communities have much better uptake of breastfeeding than white women, for example. And we know that, for example, working class white women, for example, in Blackpool and things like that, the rates are really low. But what's really important is that local understanding. So if there's something that the LMS can do to understand the needs of its community, I agree that with the safety piece, there's a huge amount of work that needs to do nationally to understand what is going on in these variations in mortality, and to really quite literally get underneath the skin of the issue and understand what all of the contributing factors to that. But locally, there's perhaps something for LMSs to do to understand their community's needs, the variations between that, and to come up with some sort of tailored strategy at how you reach different communities.
Thanks. Hi, I'm Lauren. I'm actually a GP in Barrow. What I wanted to say really was that obviously a lot of focus is often about women accessing support. But actually for a lot of my patients with, in Barrow we've got very high deprivation rates, very similar to Blackpool, and our women just don't have the confidence to actually enter a room with other women half the time, especially when they are suffering with mental health problems. And with the cuts we've had in health visiting, there isn't that same individualised support that they now receive. And I wondered really just for people to think about how we do support these women who are socially isolated because of mental health problems, because of the fact that they don't have any money to do anything. And now no health visitor who pops in regularly to see how they're doing. And there does seem to be a big risk now for these women who haven't got the confidence to attend groups that may actually be available to them.
I think that's a really fair point, and I think that's something that local services probably need to think about. And it's about looking at your whole population and all the different needs that you need there. I'm not sure how. I'd be interested to hear what you think that we could do nationally to support that.
Tim, bring back our health visitors. That's what I would.
Yeah. No, it does. No, it absolutely does. No. Yeah. It's yeah.
So, the strong message back is please do not cut the public health rather than.
One of the things that I've heard anecdotally is that the proposals around continuity of care, that the proposals around continuity of care will actually help in this regard as well, because where a midwife properly understands and knows a woman,
yes,
she will notice a change,
yes,
and a loss of confidence, a lack of enthusiasm,
yes,
from one week to the next. And I'm not familiar enough with the proposals to say, is it planned to go right through antenatal, postnatal, and right through into community, but making sure that that is an emphasis. I think you might end up solving a lot of problems with one solution.
I'd really like to move us on because there's one more area that I'd like to speak about.
I'd like to move us on too.
The last thing, there's actually one more thing that I wanted to talk about, which was how midwifery and health visiting could work more closely together, but I'm not sure we're going to have time for that in our session. So one thing that I did really want to talk about was pelvic health. The NCT talk about the hidden half of women who are suffering from mental health problems. I think it's really important we start talking about the hidden half of women's bodies actually after birth. We know that for a significant proportion of women, you're going to have some sort of problem. We know that a third of women experience some form of urinary incontinence, 1 in 10 fecal, and 1 in 12 organ prolapse. Now, we know that the GP check's an opportunity to increase rates of detection on this. But what we've seen nationally is that there's a very varied picture in terms of what kind of specialist services are available for women to be referred into when they've been identified. So I know, for example, in some areas, for example, at Chelsea and Westminster in London, there's a fantastic specialist multidisciplinary service for any women who are experiencing problems to be referred into afterwards. And I think it's funded through Gynae or MSK. I think, is they've used different funding routes to make sure that these services are available post-discharge. But then what we've heard is other people, I've had GPs coming up to me at events and saying, I identify these women and I don't know where to send them because there isn't an appropriate service. I'm seeing some incredulity here, actually.
Does everywhere not have urogynecology services?
I'm sure they do.
Right.
But do they have a specialist multidisciplinary team?
Most modern
No. This is what we've heard. This is.
I mean,
it's not my intention to run down any particular service.
I think, well, we have a postnatal perineal clinic, but I think it's difficult. Lots of women who will suffer with this type of problem initially after birth, problems will resolve spontaneously within a few weeks. There are other people where it's a continued ongoing problem, and there are other people who will have, I've had 4 vaginal births, and I have a degree of these problems, but they don't trouble my everyday life, and there are a lot of people like that. But there are people who have serious problems who need help. I mean, really the bottom line is having a vaginal birth is not good for your pelvic floor. And so if you want to preserve your pelvic floor, don't have a vaginal birth. But if you have a cesarean section, then there are other risks involved. Okay, so these are kind of things. If you go to in London at the moment, the Royal College are meeting with all the urogynecologists there, and that's what they'll all be saying. Yeah, they'll all be saying, look after your pelvic floor, don't have a baby vaginally. But that isn't. That's taking things to the absolute logical conclusion, isn't it? So if you think that having a baby vaginally is a normal, natural thing to do, like I did, then you have to know that there will be some consequences from it. Just like the rest of your body is never quite the same when you've had a baby. And most people know, anyone who's had a baby will know that. It's a question of differentiating between what's physiological change and what will resolve and what's pathological and needs some help. And I think most places should have somewhere where people have got serious ongoing problems where they can be seen. Some of those people will just need some reassurance, some help with their pelvic floor exercises, and that things will get better. Things get better again when people finish breastfeeding. Prolonged breastfeeding is good for babies, but it's not good for your pelvic floor, because when you're prolonged breastfeeding, you don't have any estrogen around, and that delays recovery of things down there. And this is another thing, again, people probably don't want to talk about. But once you finish breastfeeding after that year and your estrogen levels are back to normal, things will improve down there again. If you keep up with your Pilates, your pelvic floor exercises and all those kinds of things.
I can't tell you the number of women that I've heard from who have things like diastases recti, and they say that they didn't have any information on that. And well, no, but it's an abdominal issue, and it's something that a specialist women's health physio can help you with.
I'm also conscious that due to the amount of shuffling, we are testing people's pelvic floor right now that really want to go and go to the toilet.
Right. So I'm gonna leave it there. I just want to say thank you very much. We've ended on a high.
That joke didn't help, I don't
I just wanted to say, I hope that was, I found that really helpful, so thank you. And I hope actually that gives everyone in the room reassurance about the massive amount of work that's being done, actually even locally now, to improve postnatal care. You will be hearing from us. It sounds like most of it you've already got covered already. But thank you very much. If you have any questions, please get in touch with us.
Thank you very much. I think that was a really fantastic, really engaging. I was saying that we weren't going to have much interaction. We've had loads. Thank you.